Hi, my name is Tom Shannon. I am the Discipline Director for Physiology in the first block that you're going to have, Host Defense, and I am also the Course Director of two blocks. One will be the second block in the curriculum, the Vital Fluids block, which covers the cardiovascular system and the renal system, and then I'm also the Course Director of the Vital Gases block, which is the next one, which covers the respiratory system. And I'm also the Course Director of Sexuality and Reproduction. So for better or worse for you, you're going to be seeing a lot of me, although not very much in the first month or so, as I do have a little bit to do with Host Defense, but not a lot. So this is my contact information. If you have any questions about this video or the notes that I've distributed with the video, please email me. Don't hesitate to do that. It's our jobs to pay attention to what you have to say and try to help you guys to learn the material. And it would give me some pleasure to be able to do that. Although it's listed last on this slide, I'd like you to first notice the point at the bottom here. The way that the notes that are being distributed with these videos were written, they're meant to go with the videos. And in fact, the way that I had envisioned you using them is simply by sitting back, relaxing, watching the videos, and maybe going down through the notes figure by figure as they come up in the video, and they should follow pretty well along with what's in the notes, and then you can do some highlighting and some note-taking as you go. Now, having said that, many students find that to be cumbersome and they don't like to do it. So I have also given you the slides to go with this presentation, and if you wish, you can just watch the video, take notes on the slides. It's just fine. Or if you don't like watching the videos, you think I'm a blowhard, then you can just read the material that I gave you. The reading is a duplicate of what's in the videos. They cover the same major points, and you won't be missing out on anything if you just do one or the other. Either one alone is fine, okay? So you may ask what I'm going to be covering here. As you might imagine, it is physiology. And what I wanted to do is introduce you to some of the basic major concepts that tend to come up over and over and over again as you go through physiology and pathophysiology through the first 2 years of the curriculum. And what you'll often find is that if you can remember these major points, you won't have to go through and memorize every little thing that you have to remember, because you'll be able to just figure it out. If you remember the broad things, you can always fit the specifics into the broad concepts, and that should help you remember them. If you get through this and you tell me that you never had to memorize a thing, if you get through the first 2 years, that would be music to my ears. It probably is unrealistic, but in terms of physiology, if that's the way it turns out to be, I would love for you to be able to say that at the end of your second year. So having said that, I can't cover every organ system, so what I'm going to do is I'm going to cover just the heart. And as I'm covering it, I'm going to emphasize some of these major important concepts, physiological concepts. The heart is an excellent organ to do this with. It's one that you're all familiar with. I can say you exercise and your heart rate goes up, and everybody will know what that means. What I'm going to do is I'm going to cover this organ in different levels, starting with the organ level, the heart, and to a certain extent, what you'll see on the whole body level. And then we're going to also cover the heart on the cellular level and the subcellular level, and down to the organelles and the membranes and the proteins that you find in those membranes. And what we're going to do is we're going to integrate this all together functionally, so that you can go up and down the ladder. You can look, let's say, at a problem on the level of the proteins and be able to predict what will happen on the organ level and what symptoms your patient may exhibit. Or you could look at symptoms and you could look at what's going on the organ level and try to make some predictions about what that may mean in terms of the function on the level of the proteins. So if you can go up and down that ladder for the heart, and certainly for certain diseases and certain functions that we're going to cover in detail, that should provide you with a basis at the end of 2 years that you need to extend that and do it for any organs or any disease that you desire to do it. So we're looking to lay down a basis over the basics over the next 2 years to allow you, to give you the ability to extend that should you wish. And I would argue that you can't understand medicine unless you understand how to do this and go up and down this ladder. And I'll show you what that means over the course of the next few videos. So although we're covering the heart specifically, this should provide a little bit of a skeleton for you to hang future lectures and lessons on. For instance, I'm going to go over some of the stuff here, and I'm not going to go over it in very much detail. We're going to cover those details in exquisite detail. We're going to cover this in the vital fluids block to the point where it will become painful. And so you should remember that you should not be going through these videos and thinking, oh my God, I have to remember everything about the heart. You don't. We're only going through things generally, and we're kind of skipping over a lot of details because those will come later. And we're also trying to expose you to these general physiological topics that you're going to apply as you go through the first 2 years. And specifically, I'm going to try to concentrate on at least a couple things that I think might pop up on the host defense block before I get to you in the vital fluids block, where I can start to cover some of these things in more details. Okay? So having said that, let's get started. The heart, as you might imagine, an extremely important organ in the body. The cardiac output, that is the amount of blood pumped per minute, is about 5 liters per minute, which when you think about it, it's quite a lot. That's 10,000 liters of blood per day and 4 million liters of blood per year. That's a lot, and you are completely dependent upon the heart to supply the body with oxygen and nutrients by generating pressure, which allows blood to perfuse the various organs in your body. You might argue that this is one of the 2 most important organs in the body. Some people may argue that depending upon what their area of expertise is. Everybody thinks that's the most important. But I can tell you that in a catastrophic situation, let's say a severe hemorrhage, your body will cut off blood in circulation to every single part of your body before it cuts off blood to your heart and your brain. So I would argue that those are the 2 most important organs in the body, because they're the last in a catastrophic situation. They're the last ones that your body will allow to go without blood. Cardiovascular disease, obviously extremely important. It has been the most common cause of death in the United States in fact in the world for quite some period of time now. So what drugs will you use to treat cardiovascular diseases? You do not need to memorize these drug names. That isn't my purpose. Digitalis inhibits the sodium-potassium pump. And as we're going to find out, that serves a fairly important function in the heart in terms of maintaining sodium and potassium gradients. And when that happens, when you inhibit that pump, it initiates a series of changes within the cell that ultimately results in the cardiac cell contracting with more force and the cardiac output increasing. So by the time we are done with you at the end of 2 years, I should be able to say you treat a patient with digitalis, and you should be able to take that change on the submicroscopic level and translate it to a change on the macroscopic level. That is, what will happen to the heart rate and the cardiac output, and what will that do to the body if you treat a patient with this. Can you just memorize the effects of this drug? Yes, you can. But if we're doing your job, you won't be doing that, at least not all the time. And if we're doing our job at the end of 2 years, you should be able to pick any drug, look at the literature, and be able to look at what's there and easily figure out how that drug works and how it results in the changes that you see in the whole body level. And that's because we're going to take you from the subcellular level all the way up to the macroscopic level quite frequently over the next 2 years, showing you how that's done. Okay? We have sympathomimetics, dopamine, dobutamine, good examples. These mimic the effect of the sympathetic nervous system, as I will go through later on in this lesson. These are G protein receptor agonists that ultimately will increase cardiac output. We have phosphodiesterase inhibitors. These also act upon the subcellular, at the subcellular level, ultimately upon upon the mechanism by which the sympathetic nervous system alters the activity of the heart. In this case, it does so by inhibiting the breakdown of the second messenger cyclic AMP, and we will talk about that. And you should be able to predict what the effects of that will be by the time we're done. Calcium channel blockers, these block calcium channels, an extremely important role in initiating the process of contraction and in regulating the force of contraction. A blocker would inhibit the activity of that channel. And so you might use these under a variety of different circumstances. Beta blockers block the beta receptors, which are the receptors that are involved in the sympathetic response. So if they're blocking this response, by the time we're done, you should be able to predict what a beta blocker will do and how it will do it, simply by blocking binding to beta receptors. And antiarrhythmic drugs. We're going to talk a little bit about action potentials and how they propagate, specifically in the heart, but you should be able to translate at least some of that into the nervous system and in the activity of other active tissues as well. When propagation of the action potential goes bad, you get what's called an arrhythmia, and this disrupts the contraction of the cardiac cells and the ability of the heart to pump blood. An antiarrhythmic would prevent that arrhythmia from taking place and try to get that action potential propagation back to normal so that your heart beats and contracts at a normal rate and rhythm. Okay? All right. So having said that, let's talk a little bit about the heart. We have 4 chambers in the heart. We have the right atrium, we have the left atrium, we have the right ventricle here, and we have the left ventricle here. These are separated by valves. The right atrioventricular valve is the tricuspid valve, known as the tricuspid valve because it has 3 leaflets here. And the left atrioventricular valve, separating the atrium and the ventricle, is the mitral valve. It has 2 leaflets you can see right here. We have valves which separate the major arteries which exit the heart from the ventricles. We have the pulmonary valve, which separates the pulmonary artery from the right ventricle. So blood is going to come out of this ventricle into the pulmonary artery. We have, back up. We have the aortic valve, which separates the left ventricle from the aorta. And when we pump blood, it will go out and into the aorta and into the systemic circulation. Okay? So that's the anatomy of the situation. Let's talk about how blood flows through the heart. During diastole, the heart is relaxed and it's filling. These chambers are nice and big. As they fill, they get bigger, and the muscle is relaxed so that the heart is easily filled at this point. The blood enters the right atrium through the vena cava, and it goes from the right atrium through the tricuspid valve, which is open during diastole, into the right ventricle, and the right ventricle fills. Okay? Systole is initiated. Basically, an action potential propagates around the heart and causes the muscle to contract. When that happens, the muscle contracts, the pressure in the right atrium goes up. And when the pressure in the right atrium goes up, it exceeds the pressure in the right ventricle. When it goes up, it exceeds the pressure in the right atrium. And when that happens, see these leaflets? They're shoved closed, and blood is no longer allowed to flow Blood always wants to flow. It's like all fluids and gases. It wants to flow from high pressure to low pressure. During diastole, the pressure in the right atrium is higher than the right ventricle. Blood flows through the open valve into the right ventricle. During systole, when this ventricle starts to contract, you generate pressure here. The pressure in the right ventricle exceeds the pressure in the right atrium. This valve, the leaflets, are shoved closed, and blood is not allowed to flow that direction. It wants to. It wants to flow from high pressure to low pressure. The valve gets in the way and closes, and it stops that flow, so we call that a one-way valve. Okay? At the same time, this increase in pressure is such that the pressure exceeds the pressure in the pulmonary artery. So when that happens, the pulmonary valve opens and blood is ejected into the pulmonary artery from high pressure in the ventricle to low pressure in the pulmonary artery. Okay? Blood flows from the pulmonary artery to the pulmonary circulation. That means the lungs. And the lungs receive all of the cardiac output, all 5 liters per minute. On the left-hand side, while this is all going on, we have a similar situation where blood is returning from the lung and it is entering the left atrium. Okay? And during diastole, blood flows from the left atrium to the left ventricle, here to here. Pressure is higher in the left atrium when the muscle is relaxed. Then in the left ventricle, blood flows into the left ventricle fills with blood, just like the right ventricle fills with blood. Systole begins, the pressure goes up in the left ventricle, just as happened on the right side. This left AV valve, the mitral valve, it closes. These leaflets come together and they close. Blood wants to flow from high pressure in the ventricle, where the contraction is, to low ventricle and the low pressure in the atrium. The valve won't allow that to happen. Instead, the pressure in the left ventricle builds, and it builds and builds until it exceeds the aortic pressure. The aortic valve opens and blood is shoved into the aorta from the left ventricle from high pressure to lower pressure in the aorta, and from there it goes out to the body and it enters the systemic circulation. That is basically all the organs except the lungs. Okay? And then that blood is returned to the vena cava and the whole cycle starts again. All right? So blood flows from high pressure to low pressure. When the pressure behind a valve exceeds the pressure in front of the valve, that valve opens. Blood flows from high pressure to low pressure. When the pressure in front of a one-way valve exceeds the pressure behind a one-way valve, that valve closes and blood wants to flow from high pressure to low pressure. The valve gets in the way and it can't. Okay? All right. So, how does this result in what you may see in a patient? This is what's called an electrocardiogram. Up here we have the right ventricle, this is the left ventricle, this is the left atrium, and this is the aorta, okay? And you can see that what should be happening here is the walls of the left ventricle should be contracting and moving in, but you can see that they're really not. And the reason is because this is a patient with dilated cardiomyopathy. This is a very enlarged heart. And this patient is having trouble contracting her muscle. Okay? At the same time, because of the nature of the disease, she's having trouble closing her valves. So this is the left AV valve, the mitral valve. This is a leaflet. You can actually see it closing here. It's closing when this ventricle is contracting. Okay? And when that happens, blood should not be able to go from the left ventricle to the left atrium. But see these clouds of color here? Those are swirls of blood that are showing up on the echo, and the reason they're showing up is because blood is leaking between these two leaflets. So this is what happens when the valves don't do their job. This valve is closing, but it's leaky, and blood is leaking back into the atrium from high pressure to low pressure when this ventricle contracts. That should not happen. But in this patient, because she's got a disease, it does. The same thing with the aorta. This is the aortic valve. You can actually, if you look closely, you can see these leaflets closing. And when they close, blood should not be able to get back into the ventricle. So during diastole, when the ventricle is relaxing, the aortic pressure is higher than the ventricular pressure. During systole, you're ejecting into the aorta. During diastole, when this ventricular muscle relaxes, this valve closes. Blood should not be able to get back from the aorta back into the ventricle. But see how the blood is leaking back into the ventricle here in this echo? That's because of the dilated cardiomyopathy. She has a leaky aortic valve and a leaky mitral valve. So she has aortic insufficiency and mitral insufficiency. Okay? So this is what happens when physiology goes wrong, when these valves don't work. Blood wants to flow from high pressure to low pressure. It wants to flow from the ventricle to the atrium during systole because the pressure is going up here and it's still low here. The valve usually prevents that. In this case, it's not doing that. The same thing with the aorta. When the ventricle relaxes and the pressure drops in the ventricle, blood wants to flow from the aorta back into the ventricle. Your body won't let it do that. This aortic valve closes in that case. The pressure in front of the valve exceeds the pressure behind the valve, and blood should not be able to get back through this valve, but you can see that in this case, that's what's happening. Okay? So let's go back. That's the end of our first video. In the next video, we'll continue this lesson and we'll talk a little bit about the circulatory systems and about the function of lungs. Thank you for your attention.